Hello, everybody. Good afternoon. This is Dr. Aaron Taskin, and welcome to 15th Young Ifso Journal Club. We have a brilliant faculty today. As usual, we have one keynote session with the pioneers of bariatric surgery from Brazil. And then we have our paper discussion session afterwards. And we have two valuable papers today. And then we have many valuable panelists that we're going to have brilliant discussions today. Me and my friend, Moritz Felsenreich, who is the president-elect of Ifso from Austria, will be directing this session. And now I will give my word to Moritz to start with our first speaker. And I welcome you all for this Ifso Young Journal Club that we have started in COVID area. Now it is going to be a big, huge success, I think. And we will see what will happen. Thank you very much for joining us today.
Hello, everyone, also from my side. So some words about Young Ifso. This is a young organization under the umbrella of Big Ifso, and we are here for the connection of young people. We want to have the young people, to have some presentation skills in a safe space. We have some metabolic bariatric training, and I'm very happy to be part of this webinar together with Eren. Just some words about the webinar. So we have the question and answer box here. So if there are any questions, just type them in and we will take them and discuss them. Also, this webinar will be recorded and will be later on the YouTube channel of Ifso. And I think the most important message here is that the next Ifso Congress 2024 is in Melbourne in September, and I hope many of you will join. And let me now introduce the first speaker, Luciana El Cadre from Brazil, from the Ifso Scientific Committee. Thank you for having your talk now.
Thank you. Good morning from Brazil. Thank you for inviting me. Good morning. Thank you, Ifso, for inviting me to talk about this fascinating subject. Thank you, my friend Chitan. Let's start by taking a look in the prevalence of endocrine disorders in obesity. We have at least 3 of them seen very often in obesity. And to be very objective, none of these conditions change bariatric metabolic surgery in the long term. What remains to be answered, at least in part of them, is if bariatric metabolic surgery can interfere in the long-term evolution of these diseases. When we analyze the chance of these patients to have obesity or the chance that the primary disease evolves with obesity, our scenario changes a little bit. And yes, obesity is a very prevalent condition seen in these disorders. Let's start with thyroid. We know that thyroid status is associated with changes in the body weight and adiposity. Even in euthyroid subjects, those with TSH levels in upper quintiles have higher BMI, while variations of thyroid hormone levels, even in the normal range, may promote weight gain or impair the effectiveness of weight loss treatment. So we have here a bidirectional relationship between thyroid and obesity. And TH and TSH affect adipose tissue metabolism, and adipokines influence thyroid function and structure. We have more body weight, but this is with limited extent, as well as supplementation with T4 has modest weight loss effect. What is important here is that the increase in TSH levels because of central resistance to locally produced T3 as a adaptive process to increase energy expenditure in the excess of resistance of leptin, and bariatric surgery completely normalizes this condition. So the best treatment here is weight loss, but of concern is that rapid weight loss can alter thyroid hormone levels, the so-called famine response, potentially worsening hypothyroidism, as well as you have to have close monitoring of the levels of thyroid hormones after surgery. We have the HP adrenal axis and bariatric surgery working good together. We have increased in the axis activity as a result of weight loss, and we don't want the increase in this activity. So weight loss by caloric restriction increases the axis, because caloric restriction induced weight loss is sufficient to replicate many key features of chronic stress. And bariatric surgery does the opposite. So it prevented the activation of the axis. And what is more interesting here is that sleeve do it better. So sleeve completely diminished the tone. And one theory is that circulating ghrelin might act to modify the activity. And Roux-en-Y gastric bypass does it only partially. Adrenal insufficiency is strongly associated with obesity as well. We know that adrenal dysfunction, as we saw in the first graph, is an important factor in the pathogenesis of obesity, due in part of the similarities between metabolic abnormalities in central obesity and corticoids excess secretion, with ectopic accumulation of lipids in the adrenal cortex. But we also know that steroid-dependent patients are at a higher risk of complications following not only bariatric surgery, but all surgeries. And this is really important when we talk about staplers. This risk is even higher for patients undergoing Roux-en-Y gastric bypass than sleeve gastrectomy. Weight loss causes resetting of the axis, and for these patients with well-managed adrenal disorders, the long-term outcomes don't seem to be affected. But we have to remember that adrenal insufficiency can be a complication of bariatric surgery, mainly because of malabsorption factors for steroid biosynthesis as bile. Acromegaly is a very rare condition. And we see these patients with increased secretion of GH and growth hormone stimulated hepatic secretion of insulin growth factor 1. This is closely related to obesity, and up to 5% of patients have diabetes. What happens here is that the axis is downregulated by obesity, and this is a good thing for the disease. And bariatric surgery increases the axis. The IGF-1 is lower in the obese, and this increases after surgery. So we have long-term worsen of the axis. So these patients need special attention if they underwent bariatric surgery. One good thing to discuss here is what kills this patient. Is the disease itself or the comorbidities, because the comorbidities are very well treated by bariatric surgery. And we know even with normalization of GH seric levels, controlling comorbidities here is very, very challenging. Acquired hypothalamic obesity was a matter of concern, but today we know that bariatric surgery works in this patient. What is different is that we have more weight loss in controls than in patients with acquired hypothalamic obesity, and here Roux-en-Y gastric bypass seems to work better. Obesity is frequently associated with low androgen level in men, and true hypogonadism can worsen adiposity and central fat deposition. So hypogonadism can be a cause and a consequence of obesity. And obese men have low testosterone levels, but this does not equal androgen deficiency. So the hypogonadism can be reversed by proper weight management. So first line therapy, again, is weight management, and the prevalence in patients looking for bariatric surgery can be as high as 75% of the cases. PCOS is the most common endocrine disorder among reproductive age women, up to 15%. We had a huge increase in this disease in the last 10 years. It's a highly heritable disorder, but environment factors make a larger contribution. And here I'm talking about obesity and insulin resistance. And we have the whole of environmental endocrine disruptors as well. The pathophysiology is not completely understood. You have changes in adipocyte structure and function, androgen synthesis in the adrenal gland and peripheral tissues. You have the whole of gut microbiota and bioacid metabolism, and we have a disruption of insulin metabolism with hyperandrogenemia. What is still unresolved is if this disruption results from an intrinsic defect in the insulin signaling pathway, or it results because of environment factors. The incidence of MASH in these patients is really, really high. And yes, if you have MAFLD and PCOS, don't think twice. Bariatric surgery is a very, very good choice. We have the problem that hyperandrogenism, I'm sorry about that, is not completely treated by bariatric surgery. And hyperandrogenism is the most difficult thing to treat in PCOS. Another cause of infertility is obesity by itself. And we know today we have the Ozempic babies. You lose weight, you can get pregnant. So bariatric surgery is a good indication for that. Today, hyperparathyroidism is really interesting, its relation with obesity, because PTH has a positive correlation with insulin resistance and metabolic syndromes. For some authors, PTH is a marker of the metabolic syndrome as well as a marker of MASH. We have PTH-induced hypercalcemia, responsible for the decrease in adipocyte lipolysis. With these patients, they have an increase in prevalence of overweight, impaired glucose tolerance, dyslipidemia, and hypertension, but a low incidence obese patient with hyperparathyroidism, a lower incidence of osteoporosis. We all know we have problems with calcium and vitamin D after bariatric metabolic surgery. So there is sufficient evidence to assume that bariatric metabolic surgery has an effect on bone metabolism. On the other hand, there are multiple mechanisms affected by bariatric metabolic surgery that could affect bone health in opposite ways. So my conclusions are: the relationship between obesity and endocrine dysfunction is bidirectional, complex, and concerns all main hormonal axes. Minor endocrine disorders in patients with obesity may not affect the success of bariatric metabolic surgery in the long term. And many other endocrine effects are produced by different bariatric procedures affecting all the axes in our bodies. Thank you very much.
Thank you very much for your nice presentation. I really like this topic, and I have a first question, if I may. Do you perform always dexamethasone suppression tests in your patients before bariatric surgery?
No.
No. And you don't think it has a consequence, right?
No, I don't.
Okay, perfect. Yeah, we also don't do that, but we did it in the past.
Very good question. Very good. So the thing I'm interested in the most is about in what I think the biggest challenge in these diseases is hyperparathyroidism. For me, this is the big challenge. Because when I ended my presentation, we have two ways here. We know that the evil after surgery is PTH, because you have hypocalcemia and calcium levels would be normal because we need calcium to survive. So we are going to secrete PTH, and PTH is going to try to increase calcium reabsorption in the bowel. So, but PTH is the guy who eats your bone. So for me, this is the most interesting condition. Like 25 years ago, I remember one paper from the Mister from GERD, proposing that bariatric patients should have their parathyroids out. I really read this paper, because if we don't have PTH, we are not going to have bone reabsorption, because PTH is the one who reabsorbs the bone. But when we analyze the problem, the biggest thing is that those guys with obesity and high PTH, they have a lower incidence of osteoporosis. And this is what happened after surgery. So I think that's, in the end, it's a very good indication. And everybody is so afraid of indicating a bariatric surgery with high PTH levels or hyperparathyroidism. And I think this is the biggest indication. From my opinion, acromegaly, you have, is very rare, like 150 cases each year. But if you have one case, I think you have to consider what I said. They don't die because of the disease. They die because of CV diseases, and bariatric surgery is okay with that. And all the other axes, no problem for bariatric surgery. Oh, we have questions.
From Greece. Are there any endocrine contraindications for metabolic bariatric surgery?
So it's like I just answered. I think that for these diseases, the only one who can be a contraindication is acromegaly. But still, you have to consider that these patients die because of heart disease, because of diabetes, and not because of the disease itself. So I don't think, the main thing is to follow your patient. And for some diseases, be aware of the medications, like all diseases, like seizures, like everything you have before surgery, you have to control the levels of the medications after surgery. I think obesity in all these conditions, and I demonstrated how prevalent obesity is. I think the one who kills these patients is obesity. So obesity is best treated with bariatric surgery.
Great presentation. Thank you very much. I have also one question. Like, I do also endocrine surgery, and I was always curious about that. If you have a very obese patient with an adrenal adenoma, like more than 2.5 centimeter secreting cortisol, would you opt out for doing firstly bariatric surgery or just removing the adrenal? This always makes me, nervous when I have patients like that.
Adrenal first. Adrenal first. And if you don't treat the obesity after the adrenal, these patients will still have hypertension, and you have to, but first adrenal and then obesity. Does everybody agree with me?
Yes, I do really. And I will do it very minimal invasively, like robotic maybe. Then I will have a chance to do that. Okay, I think there's somebody raised in hand. And are there any questions from the panelists, any comments? We have a very good panelists here from everywhere in the world.
Can I ask a question? Thank you, Luciana, for this nice presentation. As you know, sometimes during our surgical preparations, the hypothyroidism is one of the challenges that we should treat it before the surgery. But some patients think that they should go on taking high doses of medication to have a better result in weight loss, because taking much more medication, they think that for thyroid supplements will result with a good weight loss success. In my practice, actually, I'm following the TSH level below 10 to decide the surgery for hypothyroid patients. Can I ask your practice in this context?
Yes, I don't know if you have the same normal reference levels here or there. my level is 5, not 10. So, but you have to consider that TSH as well as PTH, they are markers of the metabolic syndrome. So you have to have a look on TSH, but on T4 as well, because you have two conditions here. One is hypothyroidism, and the other one is false hypothyroidism. And this condition is not treated today. For the last 4 years, they decided not to treat it, okay? So if you consider that with weight loss, did you see what I mentioned in the slide? The main thing is that we have high TSH levels because you are trying to increase your energy expenditure, but this does not equal hypothyroidism. So the best thing is considering symptoms and consider TSH like a marker of the metabolic syndrome. The other important thing, be aware of T4 reposition after surgery because it changes a lot, mainly in the 3 months after surgery. So hypothyroidism is not a problem.
So we have 2 more questions, then we have to go on. First, Shahab.
Yes, thank you for your nice,
Oh, this is very okay.
presentation.
Is this your question on the chat? No.
No,
Go ahead.
no.
We'll do
Have
Shahab
another
first,
question
then on
in
the
the chat.
chat.
So thank you for your gorgeous presentation. I have a question. Sometimes we see that the PTH level after bariatric surgery increased, even with the normal level of the calcium and vitamin D. So is it important, and what should we do for these
Very
cases?
good question. Very good question. So PTH is a marker of the metabolic syndrome, and PTH can be elevated before surgery, correlated positively with BMI, okay? So PTH, you don't use it alone to control calcium supplementation after surgery. The best thing to do is to use bone reabsorption markers. We have one in the blood and one in the urine. So what I use is called CTX1, C-telopeptide 1. I've been using this for since 2011. I don't know, I'm not good at mathematics. So I'm using it like 2011, and I published a paper in this year demonstrating that PTH should not be used alone to control calcium supplementation. So bone reabsorption markers. This is very dynamic, okay? And you can, and it's very, with accuracy, both in pre and post-menopausal women. And we have another question on the chat. It's a very interesting question because Apor asked, what should be done for bariatric surgery patient on steroids? You have to continue on steroids and control the seric levels. It's not a problem. The problem is only the surgery, like I mentioned. You have more risk of leaks and so on. But if you have the chance to help this patient not to be obese, I think it's not a problem. So I think we're done with our time.
Thank you. And we'll take the last question. We have to ask you this. What should be done for bariatric surgery patient on steroids for autoimmune disorders?
That's why I just answered.
Okay. Sorry. I just missed it. And now I think it's time to move on to our second session. And we will have paper discussions in this session. And our first paper is from my friend Sonia Cipietta from Italy, from Naples. And she's the department head and director of Bariatric Surgery Center of her university. And she's the scientific committee head of our Young Ifso. And her paper is about safety and efficacy of Roux-en-Y gastric bypass as revisional bariatric surgery after failed anti-reflux surgery, a systematic review. This is a very valuable paper. Thank you, Sonia.
Thank you so much, Aaron. Hello to everybody. I will start my video directly. Good evening and welcome to this 15th Young Ifso Journal Club. It is my honor and pleasure to be part to discuss my paper, Safety and Efficacy of Room-wide Gastric Bypass as Revisional Bariatric Surgery after Failed Anti-Reflux Surgery, a systematic review. And I want to say hello to my chairs, Erin Taskin and Moritz Felsenreich. Thank you for invitation. Hello also to Luciana, Mohamed, and all the other panelists. And obviously, welcome to all the attendees to this webinar. This is my COI. This is my case mix disclosure. We are talking about obesity and GERD. Obesity is increasing in parallel with GERD, and patients with obesity obviously have pathogenic mechanisms which further develop GERD. Also, the adipose tissue have an endocrinologic role in which is related to Barrett's esophagus. So we are talking about a really important problem. When we are talking about GERD and when we are talking about the indication for anti-reflux surgery, we have three main points which indicate anti-reflux surgery. Obviously, a PPI-resistant GERD. Second, the need for long-term maintenance therapy with PPI. And, of course, the third one, extraesophageal manifestations such as asthma, hoarseness, cough, chest pain, and aspiration. So when we talk about today indication to bariatric and metabolic surgery in the presence of GERD and hiatal hernia and or hiatal hernia, obviously we are talking about the indication to room-wide gastric bypass. And we have this great narrative review from Suter, who shows exactly in his algorithm that a patient with GERD who has obesity has to be indicated to room-wide gastric bypass. A patient who had a fundoplication and has a recurrence or a failure and reoperation is indicated, if this patient is a patient with obesity, room-wide gastric bypass is indicated and not redo fundoplication. When we look, and this is another systematic review and meta-analysis where I performed with this great core group of surgeons, when we talk about GERD as an indication for revisional bariatric surgery, we see that the most performed procedures, surgical procedures in patients with GERD is the room-wide gastric bypass. In this cohort, 533 patients who underwent revisional bariatric surgery and 37% underwent room-wide gastric bypass. And in the meta-analysis of the studies, the reported GERD had a remission of 99% following revisional bariatric surgery. This is an important number. But the question is, and I had the question because I had some patients who presented with surgery with situation after anti-reflux surgery. And my personal question was, is room-wide gastric bypass the best surgery to perform? Is it safe? And if it's efficient in a situation after anti-reflux surgery? So we performed this systematic review. The primary outcome of the study was the safety of room-wide gastric bypass, including the perioperative complications up to 30 days. And the secondary outcomes were the efficacy regarding weight loss and obviously the effect of room-wide on GERD. Analyzing 606 records with all articles included until March 2022, using the keywords for the research you see here on the slide. At the end, we identified 23 studies which we could include in this systematic review, including 874 patients. Mean age of these patients was 53 years, and the interval to failure or revision after anti-reflux surgery was 5.58 years. Recurrence of reflux symptoms were presented in 21.5% of the patients who underwent room-wide gastric bypass after a failed anti-reflux procedure. 16 of the studies included Nissen fundoplication. Only 2 studies included Toupet fundoplication. 7 studies did not mention the type of anti-reflux procedure, and a concomitant hiatal hernia repair was reported in 3 studies. The preoperative studies in this patient included in all patients 100% the upper endoscopy, and this is quite obvious. Only 6 studies of the 23 reported esophageal manometry, and only 4 studies reported pH monitoring. And this is a quite important data. That means that indication for room-wide gastric bypass after failed anti-reflux surgery is quite, an important indication. That means that the surgeons trust in this indication, or also maybe for organizatory reasons, they do not perform esophageal manometry or pH monitoring. The reasons for revision included mainly GERD, 18 studies, severe obesity and hiatal hernia, only 6 ones. That means that the main reason for room-wide gastric bypass in a failed anti-reflux procedure is scared. And that obviously these patients present also obesity, and only in 6 studies the main reason was severe obesity. Mean BMI at revision was obesity grade 2, 37.56 of BMI. What about the safety? Studying, analyzing all these studies, all these 874 patients, we had a total perioperative complication rate of 16.7%. This is an important data, including mainly anastomotic stenosis, anastomotic leakage, small bowel obstruction, and hemorrhage of the anastomosis. Ventral hernia is reported with 1.83% and is also included in the 5 main complications after this surgery. When we talk about the efficacy of room-wide gastric bypass regarding weight loss, we have a mean excess weight loss of 69%, a delta BMI loss of 10 points in a follow-up with about 2 years reported in 20 studies. The mean improvement rate for GERD symptoms was 92.62%. When you remember the first systematic review and meta-analysis, which I showed you, the indication was GERD for regional bariatric surgery. There we had a remission of symptoms in 99% in the meta-analysis. So this is a little bit lower compared to the literature. When we talk about the more than 16% of perioperative complications, and we compare them to the 2 benchmark studies performed by Daniel Gero, who is also part of this journal club. He showed that in primary bariatric surgery, we have a complication rate of Clavien-Dindo higher than 3A of 5.5%. When we talk about revisional bariatric procedures, we have a 90-day morbidity of 14.6%. So in this published studies we have analyzed, with 16.7%, we have a really higher complication rate. And this is important. This is important to remember, yeah, in our daily clinical practice. So when you have a patient who present himself with a failure after anti-reflux surgery, or due to obesity, or due to GERD symptoms, or a disruption of the rib, or a hiatal hernia, remember that these patients have a higher risk of perioperative complications. So this is my conclusion. Conversion of failed anti-reflux surgery to room-wide gastric bypass might be an efficient revisional bariatric surgery regarding improvement of GERD and weight loss, because we have this improvement rate of 92% in GERD and excess weight loss about 70% in a follow-up of 2 years. But we have elevated complications with 16.7%, mainly leakage, stenosis, and small bowel obstruction. So the cooperation of anti-reflux and bariatric surgeon is important up to date. When we have a patient who present with reflux and hiatal hernia in a grade 1 obesity, discuss maybe multidisciplinary if the right indication is an anti-reflux procedure, or if it's better to perform room-wide gastric bypass. And obviously, when we talk about revisional bariatric surgery after failed anti-reflux procedures, these procedures have to be performed in centers of excellence with experienced surgeons, and obviously to minimize the rate of perioperative and long-term complications in these patients. Thank you for your attention, and I want to invite all young surgeons under 45 to be part of the next Become a Bariatric and Metabolic Surgeon Animal Lab, which will be held in Naples in February 2025. This picture shows our group in 2024, this year. The whole Young Ifso board was present, a lot of international young surgeons, and we had a lot of fun, passion, and the feedback was great. Learning was really good in the Animal Lab. And next year we have really a surgical parcours, including also the pharmacological treatment, the endoscopic bariatric surgery. And I welcome all of you. Thank you.
Thank you very much, Sonia, for the marvelous talk and the paper. First, I will ask you a question, because I think this is a big discussion, because all these anti-reflux procedures are being done in conjunction with sleeve gastrectomy, like sleeve plus toupee, sleeve plus Nissen. For my indication, I would only do it if the patient has an intestinal metaplasia and I have to check with endoscope. What is your indication? Would you offer that to a patient, or would you go right away with gastric bypass?
I completely agree with you. Primary indication is room-wide gastric bypass. This is my personal opinion. I do not perform it. Obviously, when you have a contraindication for room-wide gastric bypass, you have to discuss it, because when you have a hiatal hernia with 3-4 centimeters, maybe performing sleeve plus hiatoplasty might not be the correct surgical option, and then you can discuss it with the patient. But in my personal opinion, which is also, I think, up to date, quite underlined with evidence. Why gastric bypass is the right surgical indication.
Okay, thank you. First, I will take some comments from the panelists, then we will go with the audience. Dr. Shishik, please.
Okay, thank you, Sonia, for this nice presentation. And the subject is really so important and interesting. It's a challenging patient group who had a previous fundoplication surgery when we decide to do bariatric surgery. And I also read your studies full text, and I agree with you that there was a sentence for the patients who had a BMI maybe over 35, who had serious reflux symptoms, instead of fundoplication surgeries, maybe primary Roux-en-Y should be selected in the beginning, and maybe in the future by gaining weight, this problem will not be over by this way. I agree with you. And I have a question. In your technique, what do you think about when we solve the fundoplication, when we take out the wrap on the Nissen fundoplication, is it better to resect the fundus site because of a possible vascular problem and ischemia problem? What do you think about it?
So this is to decide case by case, and you have to decide it intraoperatively. I have to say I had just operated patients in situation after Nissen fundoplication, and going inside, you see a quite disrupted wrap, or maybe not a complete fundoplication. So it depends. When it's possible, you open the wrap and you perform then the gastric pouch. When it's not possible, we know up to date with the Nissen sleeve that obviously you can handle with the cartridge also a 2-layer situation. But if there is a high risk, or also you have to evaluate the patient. If it's a patient with diabetes, smoking, he said he stopped, but at the cardiovascular side at risk, maybe it's more important to stay at the right from the wrap and yeah, have a really safe surgery. So I decide this always intraoperatively. So I talk to the patient obviously before and what is present, but in the literature you have both. You have to open the wrap with good outcomes. You have to, they say also that you can leave the wrap. So there's no evidence for or against both.
Sonia, what
Thank
about
you,
the
Sonia.
hiatus? Do you always go for a revision of the hiatus?
If the upper endoscopy prior to surgery confirms hiatal hernia, obviously preparing the left cruise, you have to check if there is a possible hiatal hernia. I do not always open the small omentum to go also to the right cruise. It depends on upper endoscopy and the situation of the surgical cruise. But if there is a hiatal hernia, obviously I repair it.
Thank you, Sonia. And we quick question from Daniel and quick comment. Then we'll move on with the question.
Great talk, Sonia. Thank you very much for citing our studies. Regarding the benchmark studies, I'd just like to mention that the complication rates you show, they are not really rates. They are best achievable outcomes. They are like goals. They are based on the 75th percentile of the medians of the participating centers in each of the studies. So they are not exactly means of the mean outcomes. They are like clinical indicators to set like a cutoff under which the outcomes are acceptable and over which someone should start to think what could be optimized. But thank you very much.
Thank you, Daniel. And we have one last question from Dr. Lainas from Greece. And he tells that, great talk, Sonia. Thank you. What bariatric surgery would you propose for a 20-year-old patient with BMI of 42 and a Nissen fundoplication performed 3 years before for girls? And what pre-op exams would you perform in this case?
So the question is if the indication is obesity or if the indication is a slipped or disrupted rep after fundoplication, and if the patient has reflux esophagitis, yes or no. But also a young female patient, in my opinion, in situation after Nissen fundoplication, I would go to a Roux-en-Y gastric bypass because, you know, this is the second surgery. It's not ethically correct to let these patients undergo 3 or 4 surgical procedures. So when we have a problem of obesity and GERD, Roux-en-Y gastric bypass is the right indication. You mentioned 42 BMI. It would be different if this was a patient with a BMI of 32 without comorbidities. In this case, you have to discuss because maybe the patient will get pregnant in the next years, and obviously Roux-en-Y gastric bypass has a higher risk of of long-term complications. Compared to sleeve gastrectomy. So I have to say in grade 2 obesity, BMI 35, when you have no reflux and the only indication is obesity, maybe with hypertension, you can also discuss about a sleeve gastrectomy. But BMI 42, in my opinion, should be Roux-en-Y gastric bypass.
Okay, a quick comment from Luciana, and then we have to pass
Very
for
quick.
the
I
next.
think
Thank you, Sonia.
one thing very important Sonia mentioned is the gender. It's a female patient, and this should be taken into consideration. Just this.
Thank you. And my friend Moritz will introduce the next speaker. Thank you very much.
Thank you.
Thank you for this great discussion. I saw that there are 2 more questions, but maybe Sonia, you can type that in. It's about some cases. What would you do? And maybe you can type the answer so we can go on with the next presentation. It's from Turkey, from Muhammed Taha Demipurat, and he is from the University of Health Science Umrani Training and Research Hospital, and the presentation is about the development and validation of gastric model for predicting patients with suboptimal clinical response after laparoscopic sleeve gastrectomy, and the practical calculator, a retrospective study. And yeah, you can go on with your video, and then we have a discussion after.
Thank you, Maurice. Hello, everyone. Thank you for chance to present my paper. Now I will show my video. I want to thank Young Ifso Committee for this presentation. Development and validation of the gastric model for predicting patients with suboptimal clinical response after laparoscopic sleeve gastrectomy, and a practical calculator, a retrospective cohort study. This study aimed to develop and validate a regression model based on parameters that affect weight loss success in patients scheduled for laparoscopic sleeve gastrectomy, and thus preoperatively predict whether the patient would achieve successful result in terms of weight loss at the end of the first year. We analyzed retrospectively the patient who underwent laparoscopic sleeve gastrectomy between January 2018 and August 2022. Inclusion criteria are patients who underwent laparoscopic sleeve gastrectomy and who regularly attend the 1-year follow-up outpatient clinic visit. Exclusion criteria are patients who underwent other bariatric procedure or revision surgery, and patient without regular outpatient clinic follow-up. Data collection of our study: demographic data, smoking status and alcohol use status, preoperative weight, body mass index, and at the end of the first year, weight, body mass index, total weight loss percentage, and perioperative laboratory data. We used these formulas in our study. At the end of the first year following laparoscopic sleeve gastrectomy, patients with total weight loss percentage above 20 were defined as having an optimal clinical response in terms of weight loss. The primary outcome of this study was to develop a regression model and practical calculator to predict patients with suboptimal clinical response by determining the parameters associated with optimal clinical response in terms of weight loss at the end of the first year following laparoscopic sleeve gastrectomy. The patients were randomly divided into two groups, the development and validation cohort at a ratio of 3:1. The validation cohort was preserved for external validation. We examined potential predictors for outcomes using univariate analysis. We compared development cohort and validation cohort groups. No significant difference between the groups in terms of the variables. We use the SMOT technique to increase the number of the patient with suboptimal clinical response, thus enhancing the model's performance. To assess the effectiveness of SMOT, we compared the synthetic and original patient with suboptimal clinical response. We generate 250 synthetic patients after the SMOT. Upon comparison, we found no significant difference between the original and synthetic patient regarding the examined variables. We generate 250 synthetic patients from original patients. No significant difference between the groups in terms of variables. 400 patients was included in our study. Randomly divided into two groups, development cohort and validation cohort. We generate 250 synthetic patients and totally 550 patients, and validation cohort was preserved for external validation. In the development cohort, there were 22 patients who did not achieve the desired total weight loss success of the at least 21 years after the surgery. Patient with optimal clinical response, 278 patients, original and synthetic patient, 272 patients. The most important variable in our model was age. The Volt statistic of age 52.9. Glucose, age, alcohol consumption, systemic immune inflammatory index, thyroid stimulating hormone, and cigarette use status were the independent predictors of optimal clinical response. The model was called the gastric score with using the initial of these parameters. The significant parameters are ranked in terms of effect on clinical response success. The most important parameter is age, and other important parameters are glucose, thyroid stimulating hormone, alcohol, systemic immune inflammatory index, and smoking, respectively. Volt statistic, it shows the effect of the parameter on the gastric model. The mean area under the curve of the final model in the internal validation process, training value and testing value. There was only a 4.3% loss of overall performance in the internal validation process. Therefore, the final model was tested in the validation cohort. The difference between the mean training value and the mean testing value indicates the effectiveness of the model. The smaller this difference, the better performance of the model. There was only a 4.3% loss of overall performance in the internal validation process due to this minimum difference. We developed three different logit cutoff value for our model: logit 1, logit 2, and logit 3. Each logit cutoff value was determined according to the specificity and sensitivity of the model. As specificity increased, sensitivity decreased. In this table, we present the percentage of specificity and sensitivity and accuracy of logits. We recommended using logit 2 due to logit 2 is better consistency. We also provided a pragmatic, easy to use Excel-based calculator which displays the predicted outcomes for different thresholds to facilitate the external validation of our study or possible clinical utilization of our model. Why these parameters have an effect on clinical response after laparoscopic sleeve gastrectomy? How do these parameters affect the clinical response after laparoscopic sleeve gastrectomy? In younger patients, higher total energy expenditure and favor comorbidities. Poor glycemic control before surgery contribute to lower diabetic remission and less weight loss. Thyroid hormones involved in both diet intake and energy expander. Preoperative high thyroid stimulating hormone levels were positively correlated with postoperative total weight loss percentage success. However, this high thyroid stimulating hormone value in our study was within the reference range. All patients in our study were euthyroid. Alcohol consumption was one of the significant predictors. 1 gram of alcohol is equivalent to 7 kilocalories. Alcohol consumption leads to excessive calorie intake, which leads to weight gain. Overnutrition can cause an inflammatory response. Obesity and inflammation are positively correlated. Obesity induces an inflammatory index. Patients with higher body mass index have a higher inflammatory index. We know that preoperative body mass index is negatively correlated with weight loss success. Heavy smokers have been more tend to become people with obesity. The desire to smoke is positively correlated with feeling full, and snack foods are conceived to smoke. These snack foods are often caloric foods. The limitation of this study includes retrospective and single-center design, lack of socioeconomic status and dietary behaviors, and bougie size and frequency of postoperative follow-up and postoperative physical activity and comorbidities related to musculoskeletal system. The gastric score has the potential to be used as an auxiliary tool to predict the patient population with suboptimal clinical response in terms of total weight loss percentage at the end of the first year after laparoscopic sleeve gastrectomy. Younger age and improved glycemic control were fundamental positive predictor factor for optimal total weight loss percentage after laparoscopic sleeve gastrectomy. Before the clinical utilization of our score, comprehensive external validation studies should be conducted to test the performance of gastric score in different population and setting. To facilitate validation studies, researchers can utilize our Excel-based calculator. Thank you for your patience. Now, let's do example on our Excel-based calculator. Example calculation. Enter the patient's data in Excel and the calculator will give you the result of weight loss success. We recommended logit 2 because it's more consistent and have balanced specificity and sensitivity. Enter the patient data. The result is unsuccessful for patient 1. Patient 2, no smoking, no alcohol, age 38, fasting glucose 105, thyroid-stimulating hormone 1.95, and systemic immune inflammatory index value. The result is optimal clinical response for patient 2. Thank you.
Thank you very much for this presentation. And I think before we start the discussion, I want to thank our panelists because not all of them were here when we have started. So I will shortly introduce them. There was Daniel Gero from Switzerland, who is the Young Ifso chair of the communication committee. Then next we have also a guest panelist who is Dr. Abdullah Sisik from Istanbul, Turkey, associate professor and Congress Secretary of the 9th Obesity Metabolic Disorder Surgical Congress. And also, of course, Shahab Shabani from Iran, who is the Young Ifso representative of the Asian Pacific chapter. And I think we can go on with the discussion now. Are there any questions? So I think it's a very nice tool. So for how long you are using it now, Mohammed?
Hello.
Can you hear us, Mohammed?
Yes.
Moritz
Yes.
asked you a question. How long have you been using this scoring system?
We generate this score in this year. We use this score. We have used this score for 4 or 5 months.
And just for sleeve gastrectomy or also for other procedures that you're doing?
The gastric score should be validated in different population in the clinical utilization. The different population.
Okay. Any other questions? Sonia, yes.
Congratulations for the idea. This is really, really important because up to date, every surgeon decides which surgery to perform, and to have a validated score is really important. My question is, in your daily clinical practice, when you perform the score and you see unsuccessful in every 3 outcomes, do you indicate then gastric bypass?
Yes, the gastric bypass procedure may be planned for patients who are not expected to have an optimal clinical response after laparoscopic sleeve gastrectomy. But firstly, the score should be validated in the different populations. We use this scoring system, but it's not enough only we use.
Yeah, so my idea is, as the Young Ifso scientific head, to perform maybe a platform where anonymized all of the young Ifso and also the big Ifso, obviously after ethical approval, can put their data, and you perform a big data to validate this score. I think for all of us, it would be a great possibility.
Yeah, I think so. It will be very nice to validate it because it seems to be working. But sorry, Abdullah, I think has a question. But I have a question also. Like this, you put the smoking. So if you offer gastric bypass, if sleeve is not working, would you do that? Then, sorry to disturb your question, Abdullah. Because there is a parameter smoking in your parameters that you choose.
Yeah.
So would you offer gastric bypass to a smoker if sleeve is not working, or would you do something different like SASI, transit bipartition? I don't know. Because the patient is smoker, and if you do a gastric bypass, there will be anastomotic ulcers. So if it's not validated because of smoking, like if it's unsuccessful because of smoking, would you offer bypass? Because in the scoring system, there is smoking parameter.
We recommended all patients to
like, would you offer gastric bypass if?
I mean, I can maybe answer that.
Yeah.
So we are also recommending to all our patients to stop smoking, but in Austria, smoking actually is not a contraindication to gastric bypass, neither VGB nor Roux-en-Y gastric bypass. But of course, this is a good point, and I think at least if the patients then have an ulcer, then they need to stop smoking because it will not heal, and also reoperation, as we know, is not very successful if they still continue with smoking. But yeah, so I think smoking is a very good point. But
Okay,
I see Abdullah is waiting so long for his questions already.
Yes. Yes, sorry.
No problem. I want to do a contribution, and it was interesting the method of this study because a different technique is used, the SMOT technique, the synthetic minority oversampling technique. So they increased the unsuccessful patients, number of patients. Maybe this will be a good tool for different complication in bariatric metabolic surgery. For example, very rare complications can be studied by this statistical technique, and this will be a good lightning for this kind of studies. I congratulate Dr. Demirpolat. Thank you.
Thank you very much.
I want to make last comment. I think also Luciana also made this comment, like the TCH value, because we see that also in this scoring system, the patients who have higher TCH values have better weight loss, like who are not like more than like reference range, but who have higher TCH values have better weight loss also. So this has been validated.
Yeah, I do congratulate Mohammed for this paper, for this work, for this score. But, you know, from my point of view, this type of thing is so difficult to be predicted, even with scores, even with like childhood scores, with genetic scores, so I think that we should have data like Sonia mentioned, because you cannot deal with numbers. If you have a high number, then you can have a conclusion. This is my opinion.
Thank you. Thank you very much.
Thank you, Luciana. There are many parameters that affect weight loss after the surgery. There are also parameters that we could not include in the study that affect weight loss success. We mentioned these parameters in the limitations section. Among the parameters we include in the study, we cannot say that it was only the parameters included in the scoring that affect weight loss success. The absence of diabetes mellitus as a comorbidity and having a low body mass index were also among the significant parameters. But the fasting glucose explained weight loss success affected by the diabetes mellitus, and the more effective systemic immune inflammatory index, thyroid-stimulating hormone value explained the weight loss success affected by low body mass index. We would like to state that more successful results can be demonstrated with the prospective and multi-center studies, including the all missing parameters. We believe that our study will be contribute to the prediction of optimal clinical response before the bariatric surgery. Thank you.
I do believe as well. But I think for us to have scores in chronic diseases like obesity, like diabetes, we do have numbers. We have to have numbers, because we are talking about multifactorial diseases, chronic diseases. So to validate any kind of score predicting success in the treatment of these diseases, we need numbers. Numbers with statistical strength. For instance, if we can debate about fasting glucose, it's very, very easy to explain. If you have a lower fasting glucose, you have a lower insulin. So insulin, what is the job of insulin? Is to fat deposit, to give you, to make you hungry. So I think if we had numbers in any type of score, considering this chronic disease, then we can validate the score. Sonia is nervous. She's like,
I think we will do it all together. Thank you very much,
you.
all of
Thank
you, for making this journal club session a huge success. We have more than 60 participants today. And I want to thank all our speakers and panelists for doing this successful journal club. Thank you, everybody.
thank you.
Please, Moritz,
Thank you.
if you have few words for closing, tell us, and then we will close it.
I just want to wish Erin the very best on your wedding. Okay.
Thank you. Thank you very much, Luciana. Thank you, everybody. I
Also from my side, Aaron, all the best for your wedding.
All
There
the
was
best.
just one
Thank-
comment was there
Thank you.
at the question and answer, but I think it's for you, Mohammed, about some limitations. You can read it, right? And we see us next time. I think our next meeting is in Melbourne. I hope we see us and as many as you can join the session, even if it is far away. And yeah, we also have in I think 4 months the next webinar, the Young Ifso webinar, and see you all then. Have a nice afternoon.
Thank you.
Evening.
Have a
Bye.
nice day.
Have a
Thank
nice day.
Bye.